doing your introduction.
Sure. Hey, folks, I am Katie Chesson-Downs, lead clinician for addiction services here with WVU Medicine in Morgantown. Thanks so much for joining us. Always takes me about 47 tries to make sure that I share my slides correctly. So let me do that now. And I know I got to do this switcheroo. Can you guys see them correctly? Great. I see head shakes. Yes. Okay. Thanks so much for your time today. We're going to be talking about really the most common therapeutic approaches and modalities that we use with our substance use disorder population. The list that I'll be talking about is not inclusive of all of them. If in order to talk about all of them, I would need hours with y'all, and I got about half an hour. So I'm really just going to be highlighting the kind of main ones that we use. Derek, I see you repping the flower shirt. Well done. So as medical professionals, it's our job to provide our patients with the best care, also maintaining professionalism and compassion at the same time. And so one of the ways that we can do that is by facilitating appropriate psychosocial modalities. And we do that using evidence-based therapeutic approaches. Here's a list of the most common modalities that we're using when we're working with folks with SUD. So we've got individual therapy. That's really the ideal modality for patients that have other co-occurring disorders, history of experiencing trauma, which we know applies to the majority of our peoples. We've got group therapy. This is the main modality recommended for patients. And for those of you on the call that either participate in group therapy or run those groups yourselves, you know why, right? The support and the accountability they receive from their peers can be incredibly influential. And then also listed here is family therapy and couples therapy. We know addiction doesn't just involve the individual, it involves all the other people in their lives. And if we have the opportunity to bring those other members in with that patient's consent, we can really potentially affect the patient's kind of care and their prognosis on a bigger level. So for those of us, again, in the therapy world, we really see firsthand the importance of the work that we do and the effect it has on our patients' long-term recovery. For other medical diseases or disorders, sometimes the treatment really just needs to be medication alone. But for our patients, we know that adding therapy to the treatment plan helps in so many different ways. It helps address that underlying trauma that's occurring for so many of them. It can help address the needs of other co-occurring disorders they may have that aren't really being addressed by just medication alone. It's gonna provide the patient the opportunity to learn about and develop coping skills, which they can do that both in an individual and group setting. As I mentioned before, that support and the accountability, the validation they receive from their peers is immensely helpful. And then in all of the modalities discussed before, we have the opportunity to throw some education their way, to throw training their way. As you can see from that meme, I never recommend therapists to spray patients with spray bottles, just FYI. So again, here's the modalities we're going to talk about today. This list is not exhaustive. It's really just a few of the most recommended ones. So you're going to hear me today review cognitive behavioral therapy, or CBT, dialectical behavior therapy, or DBT, motivational interviewing, and we'll talk about contingency management. Here's a few, I call them honorable mention. We're going to talk just a little bit about, mostly in response to time, but we'll talk about relapse prevention, mindfulness-based practices, 12-step facilitation, and matrix model. And Elizabeth, I'll ask you, when I'm sharing my slides, sometimes I have a hard time seeing the chat box. So if anybody has any questions along the way, we're a small enough group. Please feel free to unmute yourself and ask along the way, or if you guys see any questions, please feel free to interrupt. Thanks. So cognitive behavioral therapy, or CBT, this was founded in the 1960s by Ellis and Beck. It is a psychosocial style of therapy that focuses on challenging and then changing what we see as kind of unhelpful cognitive distortions and behaviors. It helps improve emotion regulation and then helps them develop personal coping strategies. The idea is if we can kind of find a connection between our thoughts, feelings, and actions, the hope is that's going to increase our awareness of what impacts our recovery, either good or bad. CBT has the greatest evidence basis for the treatment of substance use disorder, but I would argue that one day down the road, that's going to change with DBT. I don't know if there's any DBT practitioners on here, but when we talk a little bit about what DBT entails, it's got components of CBT plus a lot of other great stuff. And so I think this has the greatest evidence basis, frankly, because it's been around longer and has been studied longer. That's just my opinion. Would love to hear from other folks on that. And so the ABCs of CBT are the idea that there's an activating event that takes place, which then ends up triggering our current belief system and our thought process, which then leads us to a particular emotion or feeling state. Now, I particularly love CBT because it's a collaborative process between the person and their team, their therapist, maybe potentially other group members. It really requires the participant to be active in their treatment. It's really nothing, it's not something that's going to be successful if they're just sitting on the sidelines. It's structured and it's focused, which a lot of folks really benefit from. It focuses on present thinking and feeling. And again, it can be used in the context of group or individual therapy, which I like. Side note about CBT, there are a lot of free apps out there. If you go to the App Store that provide CBT modules and like active journaling that can be looked at throughout the week. So while there's a lot of paying apps for CBT, there's a lot of apps that sort of good programs really recommend, just FYI. Within the COPE model, we utilize CBT both in individual and group settings. And doing this is a way to help them recognize, again, to identify which triggers for them often lead to use. It helps them learn how to avoid those triggering situations, and then also teaches them coping strategies so that they can address those thought processes along the way, reframe those thought processes along the way, and recognize what emotional space that's leading them to. Dialectical behavior therapy, or DBT, is again an evidence-based form of psychotherapy, and it's used to treat people with multiple mental health conditions. It was developed by psychologist Dr. Marcia, I hope I'm going to say her last name right, Linehan. I apologize if that's wrong. Developed by her and her colleagues in the 1980s. It's again based on cognitive behavioral therapy, but has a lot more to it. So the main difference between the two is DBT focuses on validating and accepting uncomfortable feelings rather than avoiding or working around them. Consists of 4 key components. So there's individual therapy, there's group skills training, there's phone coaching, and there's a consultation team for therapists. I'm going to circle back around to why this concept of a consultation team is, I think, important for all of us and really important for all the modalities. So DBT provides clients with new skills to manage painful emotions and decrease conflict in relationships. Specifically focuses on providing therapeutic skills in 4 key areas. So the area of mindfulness focuses on improving an individual's ability to accept and be present in the current moment. Distress tolerance is geared towards a person's tolerance of negative emotion rather than trying to escape from it. Emotion regulation covers strategies to manage and change intense emotions that are maybe causing problems in a person's life. And then interpersonal effectiveness, this really consists of techniques that allow a person to communicate with others in a way that's assertive, maintain self-respect, and strengthen those relationships. The meme over here, I have a tendency to do that if I'm feeling sort of overwhelmed in a particular area of my life. Instead of addressing that overwhelming area, I think I just need to change this other random part of my life, and that's going to fix it all. Any questions along the way? I'm not seeing any. Well, hold on. I'm not seeing anybody, although there's mention of tacos, which I always would like to see. Okay. Motivational interviewing. So MI is a counseling approach designed to help individuals resolve ambivalence about their substance use and then support efforts to change it. MI is often delivered as kind of a brief intervention based on client-centered principles. And so one of the core stances of motivational interviewing is that for the clinician, they aren't arguing in favor of change. They're not attempting to convince patients that change is or not in his best interest. We're really trying to elicit the patient's own arguments for change. So we want to establish the treatment site as a supportive, non-judgmental environment, that we're not here to tell them what to do, and we're not here to tell them they're wrong if they make decisions we don't agree with. We are here to support and honor the decisions they're going to make for their own life. Hopefully that's going to promote a positive collaborative relationship between the clinician and patient, that they see us as not as a kind of us versus them, but that we're there on their team to help them decide what they feel like is the best for them. The hope is, because they're coming to a non-judgmental environment, that they're going to sense this is a place they want to be, and that will help them engage in treatment. I would use, I think Sarah's on this call, the last echo that we had when she was talking about her THC group, I would say that's a perfect example of those patients have, she's been able to engage those patients and retain them in treatment a lot longer than maybe have in the past. And it's because of the non-judgmental environment that she's providing those folks. Because of all these previous strategies, the hope is that's going to start to reduce resistance to making change. And then we can help patient maybe start to recognize what are the negative consequences associated with those use. And those consequences aren't being sort of shouted at them from other people, but they're really discovering that on their own. So MI emphasizes a strategic use of sort of common counseling skills, things like reflective listening, summarizing, paraphrasing. Advice is typically only given out on request and rarely with patient permission. Motivational interviewing is also sometimes combined with other types of interventions like CBT in order to enhance treatment retention and engagement. And for a lot of therapists, what's happening is they're sort of toggling back and forth between a couple. As we're looking at this list, when we talk about change talk, so change talk is language or things that we as clinicians say or do that decrease the resistance and moves the clients in a positive direction. And that's often about validating all along the way and sort of helping them see what their goals are. And then sustained talk is language or things that we as clinicians say or do that really increase the resistance, that move the clients towards resistance and staying the same. And sometimes that can come from those confrontational language that we accidentally use. We'll talk now about contingency management, which many of us are familiar with as we've been participating in contingency management projects with the state's directives. So contingency management, or CM, is a technique that employs the systematic delivery of positive reinforcement for desired behaviors. So vouchers or prizes can be earned for certain behaviors. Examples of that would be when folks submit a substance-free urine, or when folks attend their required mental health appointments, things like that. We do want to keep it simple. We want them to be easy to track target behaviors, and that we want to make sure there's a little burden on the counselor or administrative staff in order to participate in the CM. We don't want it to feel like it's a punishment to our staff if it's a whole bunch more work or money. I'll say this is often the intervention that seems to bring up the most staff resistance, which we do want to acknowledge and honor. The kind of two most stigmatizing thoughts about contingency management I hear is that patients should not have to be paid or bribed, and that recovery, quote unquote, should be the reward, and that motivation should come from within. That's at least the feedback I hear the most on. And so as clinicians, we really want to reframe contingency management is it's an engagement and retention technique that we're using with other interventions and approaches. And sometimes what we can do is if we can show staff kind of firsthand how patients are responding to it in the moment, or sometimes it's about sharing, data with them about where it's improved elsewhere. Sometimes folks are a little bit more willing to at least give it a shot. Basic behavioral principles of contingency management. So it's all about frequently monitoring that target behavior, frequently, every time providing an incentive when that target behavior incurs, and then remove incentive when target behavior does not incur. Now notice that's not confronting, giving shame, anything like that. It's just about not having that sort of extra incentive in place. As you can see, my pig responds very favorably to strawberries as her incentive. And then we just want to repeat this loop over and over and over. So I'll wrap this up with briefly mentioning these other modalities. So we've got relapse prevention up there on the list. This is incorporating CBT strategies, emphasizing awareness of triggers and warning signs, and hopefully this is going to help establish social support. We've got 12-step facilitation listed on there. That's really seeking to, it really uses 12-step programs as a guide and to support engagement in programming. This was actually studied as part of a Project Match study that was back in the 1990s. It's a manualized treatment that emphasizes the 12-step concepts of acceptance, surrender, and getting active. This modality tends to be more seen in inpatient settings. There's mindfulness-based interventions on here. So that's really a broader term. It's not one specific modality. Mindfulness-based relapse prevention, DBT, and ACT all really have mindfulness-based components. But essentially, mindfulness is a type of meditation in which you're going to focus on being sort of intently aware of what you're sensing and feeling in the moment, without interpreting it, without placing a judgment on it. When we talk about mindfulness, there's so many strategies that can be included in that. When we're talking about relaxation, breathing, that's a type. When we're talking about guided imagery, any other kind of practices that either connect body and mind or relax body and mind, those are all examples of mindfulness-based practices. And then the matrix model on there, that's also a manualized program. It's specifically a 16-week psychosocial approach used primarily in outpatient settings. And it's designed to kind of integrate several different interventions into one approach. And so finally, here's my plug. What's most important, I think, with each of these modalities, if you've got a group of therapists in one department and they're all participating or facilitating different modalities, the most effective kind of therapy is therapy that's given by a therapist who feels supported and validated. It's really imperative that we as therapists participate in regular supervision to manage our own thoughts and emotions that are coming up as we're working with a challenging population. In addition to supervision, we want to be able to have regular consultation with our colleagues. That can help us problem solve in the moment. It's going to help us implement effective treatment in our challenging situations. That's one of the things I love getting together with the therapist I work with, because we can spitball, we can share ideas. Something that worked really well for me in a group therapy session, I want to share that with my colleagues and vice versa. We also want to make sure that we're providing space for each other to honor the grief that we are going to experience working with this population. And that's not if, but that's when. If I asked for a show, I know not everybody has their camera on, but if I asked for a show of hands for how many of us have lost a patient within the last year, I bet a lot of us in this room would have our hands up. Yeah, I'm already starting to see some. And so we really need to give each other the time and space to express that grief. Thank you for your Zoom hands. I forgot that's an option. And then finally, my favorite type of support I get from my colleagues is the art of humor. I had to restrain myself from not including 87 memes about therapy in this presentation. I feel like therapists are sometimes the butt of some jokes, which I'm totally fine with because a lot of them are great. So we can use humor to get through the good days and the tough days. To me, that gets me up and at 'em for the very next day. And then my final comment is just for everybody on here. Thanks for all that you do. Not every person on here is a clinical therapist, but boy, that does not mean that you are not participating in the therapeutic process. And to me, that's another important sort of point to be made, is that everything that we do in the context of treatment either sets us up to have a great therapeutic relationship or can potentially get in the way of that a little bit. So all of the staff on the team play a role in this being a helpful and healthy place for therapy. Here's my buffalo plaid for Houston and Derek.
That's perfect.
Yeah.
Yeah. Love that. Thank you so much, Katie. It's always a wonderful job. Very thorough and just, I'm sure, relatable for many in here. Does anybody have any comments or questions?
Any DBT folks on the call that have thoughts on whether you think that's going to overtake CBT one day is the, most evidence-based for SUD. Or you can tell me I'm wrong also. Okay.
Is that the therapy where you accept?
Yes, great question, Elizabeth. Yes, so CBT was the sort of initial one we talked about. It's really mostly focusing on reframing our thoughts and feelings. DBT has a lot of different components to it. There's a mindfulness component to it, as well as a CBT component to it, as well as an acceptance of what's going on with us, as opposed to sort of trying to avoid it. Yeah.
Thank you. I'd like to hear their thoughts on.
What do you think about eclectic approaches to therapy?
Yeah, great question, Dr. Hirschler. I think if I think about the best therapists I work with or get to observe in the moment, often I can't tell if I had like a checklist in front of me and was sort of checking off which kind of therapy they were doing. Oftentimes I can't tell. They're just so smooth within them. And they're really toggling between a couple of different ones. So Sarah in the comments said DBT and MI work together really well. That's a great example of sometimes you're based on what you're talking about in that moment with the patient, you may kind of be going towards this avenue or this avenue. So I like the eclectic approach. Sometimes what I see with, and maybe particularly newer clinicians, what they do is sort of take one concept from each of the therapeutic modalities without really spending a whole lot of time getting really familiar and confident with that approach. And so that sort of will kind of make me nervous a little bit, but I think getting to know and familiar and comfortable and confident with a couple of them and blending them together when you're working with a patient is a great idea. Great question.
Thank you. There's a chat saying, I think they both have their worth. It is meeting the client where they are.
Yes, absolutely. Yeah. Yeah, totally agree.
Katie, thanks for that really clear presentation. My question is about DBT and what sort of, I'm a medical provider, not a therapist. What sort of training does a person need in DBT? Not a therapy person, a behavioral health person, not a medical person, but what kind of training do they need in order to be able to offer it or to be comfortable offering it or be solid offering it?
Jennifer, you ask a great question. I'm going to ask if I can put Sarah on the spot with this question. Sarah, you're welcome to say no. I just know she is familiar with this training. And I don't want to. Sarah, if you don't mind to answer that for me, just because I know she's in the middle of that training. Sarah, can you hear me?
Sarah, I think if you hit *6, if you're on the phone, it might unmute you.
Yeah, sorry.
There
It kept like the camera was weird. Anyway, so there is a certain training for DBT, and we're working on a DBT substance use program currently at WVU, and that DBT is a little bit of a different animal where there definitely has to be some sort of consultation group with it, but there is definitely an element where it comes to the clinician and not just, the therapeutic aspect of it, but the clinician and all sorts of aspects of the team, from the case manager to any sort of provider, anything has to be part of a DBT team. And I think that kind of element where you get to go to consultation and talk about each client, and it's not just substance use clients, but it's all clients that are involved in any sort of DBT treatment that kind of go hand in hand, and that kind of unified, I guess, treatment team helps everybody be accountable for each aspect of it. And again, this is in the elementary stages of WVU medicine right now. But I think you don't have to have any particular training. It's important to go to training, don't get me wrong, but anything sort of with Marsha or Lane, Peterson, any sort of treatment that you can kind of get in contact with or be privy to, I think is important, because there is a certain protocol with substance use and also DBT where it helps people get back to the basics and recognizing what they're not fulfilling when it comes to, you know, what they might need at the home or what they might need when it comes to, you know, anything, you know, when it comes to living life. And so that kind of recognition of, okay, yeah, I eat well, I make sure I stay hydrated, all the basic stuff that sometimes we don't always recognize. And so that kind of thing can kind of incorporate a little bit of confidence. And I think that, you know, starting from a place where it can recognize that it's important that you have some of the basic things that you don't think you have, and until somebody steps back and like, hey, I don't have access to water, I don't have access to a vehicle, I don't have access to, you know, consistent food sources. It's all those things that say, okay, well, you know what, I've crossed these things off my list, so it's a good thing. And as we kind of go forward and have a team aspect of it, of consultation, I think that also helps us keep it in as practitioners, like it keeps us in perspective and keeps it important in the forefront, where sometimes we don't always take those things in consideration because we do, I don't want to say take them for granted, but I guess for lack of a better term, it's take them for granted. Like we have nice housing, we have, you know, food, we have lights on, like we don't have to stress about those stuffs. And so DBT kind of takes a different perspective sometimes on those things.
So Sarah, are you saying that it's good for the whole team to have some at least exposure to DBT? And not just like having the therapist be well trained in it, but have the team understand how it works.
I do think it's important. I can't figure out how to turn my camera back around because technology.
You're fine.
But yeah, I do think it's important that there, you know, every therapeutic aspect is important in my opinion. Just whatever fits with you is what fits with you. And you know, DBT is my jam. Like there's so many different aspects that's important to me that really fit hand in hand with what kind of works with my personal practice and you know, the stuff that I've gone through in life, and you know, working in this field of addiction for so long, like it's important to me for what I observe, not just inpatient, but outpatient. And sometimes like having that ability to kind of, I guess, have that, you know, I know privilege, for lack of a better term. Like I'm lucky that life has granted me some great things where I can help other people go through the shit, for lack of a better term. And so like some experience with that, or just even just remembering it's important to meet people where they are. And, you know, that's kind of what really DBT personally has brought to my table. And recognizing that, hey, you know, maybe people need housing, maybe people need the ability to keep the lights on. Like literally on Friday, we incorporated a client in my co-group that said, hey, I can't keep my family warm. And so of course she can't focus on any sort of, you know, sobriety if she can't keep the lights on in her house and her kids warm. So it's those basic things that help me as a provider to present to my DBT group that says, hey, you know, help me keep involved in this client's treatment. And it's not just me, it's my whole DBT consultation group. It's more accountability, not just for my client, but as a provider itself.
Sarah, thanks for that. And thank you for making the distinction. You know, Jennifer, your initial question, you can certainly provide DBT skills and kind of review DBT skills with your patient, but to be sort of identify yourself as yes, I am a DBT therapist. There's a formal training, and there's a couple of levels of that training. Is that right, Sarah?
Yes. Yes.
Yeah.
And I'm currently working on my DBT substance use training. It's very, very particular because it's such a very widespread kind of training, but initially just getting informed of what DBT is, and not just any DBT or any sort of modality. Just I think the basis is to be just informed in therapeutic interventions, not just DBT or MI or anything. Like, just be informed, be it trauma informed. Any kind of intervention that helps meet people where they are is what's important to me. I think as a basis of a therapeutic intervention.
Yeah. Yeah, thanks for that, Sarah. Thanks for that. I had not been through the training, so it was perfect timing that you were here to talk about that.
Great. Thank you so very much, Sarah. And thank you, Katie and Jennifer, for those questions. Does anybody else want to build upon that or have any comments or questions? Go ahead, Dr. Hershey.
Yeah, I have a question. I don't mean to monopolize or anything, but I'm interested in what you feel the targets are of therapy. I like in CBT, maybe dealing with triggers and high risk situations, and dialectical behavior therapy, coping with distress and that sort of thing. But what is the aim, I guess, is what I'm trying to get at, and how do you know if you're succeeding?
Yeah, first of all, Dr. Hershey, that's not monopolizing. That's a great question. And I'm going to give a wishy-washy answer, and it's not my intention to do that. But most importantly, my aim is going to be, has to be determined on with the patient. I want that to be patient-centered. And I'm aware that every patient coming into my office may have a different goal for therapy. So I may have my ideas about what they, should be working on. But ultimately, it's going to be about figuring out what they want to get out of therapy. And then 2, deciding if therapy if I'm going to be a help to them with that. And then 3, kind of figuring out that path together. Now, oftentimes when folks are coming to my office with substance use disorder, their overall aim is to increase the quality of their life. But what that looks like for them might be different than what I would assigned for them, but I'm going to go with theirs. If that makes sense.
Makes sense to me.
And sometimes, not to butt in, but sometimes what they say their goals are different than how they behave. So some people might say, oh yeah, XYZ, but when you look at for instance, their levels of THC, and it's reducing. So they might say, oh yeah, no, I'm never going to stop using pot ever. But you look at their levels of THC in their urine drug screens, and it's reducing. And it might be maybe, 100 micromilligrams or something to that effect, but it's still reducing. And so if you see this consistent pattern, what they say and what they do are 2 different things sometimes.
Yeah, agreed. Ooh, my husband would tell you I probably do the same thing. What I'm saying to him and how I'm responding to him is probably different.
Totally the same thing. Yes, I feel that.
That is totally true. Any other questions or comments? Thank you so much, Dr. Hershey, too.
Yeah.
All right, looks like we are at that time then. If you do have any for next time, just, make sure you bring them to us. We'll be happy to discuss. My only announcement then today, besides giving you back some time, April 24th, outcomes related to MOUD, and that will be by Tony DiCiacchio. So we really look forward to that. And I hope you guys have a great rest of your week.